Welcome to this infographic-based educational activity where Dr. Rohit Lumba from the University of California at San Diego discusses the diagnosis and treatment of non-alcoholic steatohepatitis.
As you know, non-alcoholic fatty liver disease is the most common cause of chronic liver disease in the United States, as well as worldwide. We think about 1 billion people may be inflicted with non-alcoholic fatty liver disease globally. In the United States, we think approximately 80 to 100 million Americans may have non-alcoholic fatty liver disease. We are identifying increased prevalence of non-alcoholic fatty liver disease in high-risk group of individuals, such as type 2 diabetes. In a study done in San Diego in primary care setting using advanced MRI techniques, we found that the prevalence of NAFLD was 65% among patients with type 2 diabetes. Other diseases or comorbidities where we find high risk include obesity, higher features of metabolic syndrome, polycystic ovarian syndrome, hypopituitarism, hypogonadism, obstructive sleep apnea, patients with hypothyroidism, patients with psoriasis, as well as pancreatic duodenal resection. NAFLD is a spectrum of liver diseases that can be divided into two broad subtypes: the non-progressive form of fatty liver disease called non-alcoholic fatty liver, and the progressive form of non-alcoholic fatty liver disease called non-alcoholic steatohepatitis or NASH. NASH is typically characterized by presence of steatosis, lobular inflammation, and ballooning on liver biopsy with or without perisinusoidal fibrosis. In individuals who consume little or no alcohol and who do not have a secondary cause of hepatic steatosis or fat in the liver, such as alcohol use, medications. Once you have NASH, you can have progressive fibrosis and you may go on to develop progressive liver disease leading to cirrhosis and hepatocellular carcinoma. Patients with NASH can also develop hepatocellular carcinoma even without having cirrhosis. Typically, the risk of hepatocellular carcinoma is higher once you've developed cirrhosis. The risk of hepatocellular carcinoma in a patient with NASH cirrhosis is thought to be somewhere between 2 to 3% per year. Therefore, we typically consider screening and surveillance for hepatocellular carcinoma in anyone who has NASH cirrhosis. Patients with earlier stages of fibrosis or those with NASH, the current guidelines do not suggest routine consideration for hepatocellular carcinoma screening or surveillance. Non-alcoholic steatohepatitis Clinical Research Network has established a NASH CRN histologic scoring system. This scoring system allows us to assess activity of disease by using a scorecard termed as NAFLD Disease Activity Scoring System, or NAS score. It includes three variables: steatosis, graded from 0 to 3, lobular inflammation, graded from 0 to 3, and ballooning, graded 0 to 2. In addition, we also look at stage of fibrosis, that is staged as stage 0, no fibrosis, stage 1, stage 2, stage 3, bridging fibrosis, and stage 4 as cirrhosis. These are important histologic milestones as a patient is developing progressive liver disease, and we utilize these in the setting of clinical trials that will become relevant towards the later half of this discussion. Moving on to non-invasive assessment of steatohepatitis and advanced fibrosis. This is a major unmet need in the field currently, and emerging data suggests that we can use clinical prediction rules as well as elastography-based modalities for risk assess these individuals. In patients with non-alcoholic fatty liver disease, higher features of metabolic syndrome predict presence of steatohepatitis, and its presence or multiple features of metabolic syndrome trait can be used to target patients for consideration for a liver biopsy assessment. Among the clinical prediction rule, the most commonly that I use is called FIB4. It includes an assessment of ALT, AST, platelets, and age, leading to these four parameters that could be clinically useful to look for advanced fibrosis or rule out advanced fibrosis in patients with NAFLD. We are also increasingly utilizing elastography-based methods such as VCTE, vibration controlled transient elastography, or magnetic resonance elastography. These could be used to assess presence of advanced fibrosis in patients with NAFLD. Typically, a cut point of VCTE or FibroScan below 6 kilopascal or MR elastography cut point of below 2.55 kilopascal is associated with low risk of having fibrosis or advanced fibrosis. Any patient with a VCT of 8.6 or higher, we think there is a possibility of advanced fibrosis or fibrotic disease, so one might consider a liver biopsy assessment. For patients with MR elastography, an MR elastography reading typically above 3 is associated with presence of fibrosis. What about advanced fibrosis? We have data on presence of advanced fibrosis and new cut points have been proposed. What we typically see is that an MR elastography reading of 3.63 kilopascal or higher is associated with 92% accuracy for identification of advanced fibrosis among patients with non-alcoholic fatty liver disease. You could assess patient based upon presence of higher FIB4 readings. If a FIB4 of 2.67 or higher, those patients have a high likelihood of having fibrotic disease and may also have presence of advanced fibrosis. So I would recommend following those patients in a liver clinic, and you might consider them for liver biopsy assessment if clinically indicated. Those with a FIB4 below 1.3, especially those below 1, would have low risk for fibrotic disease, and you could follow those patients every 1 to 3 years, and if FIB4 score increases to a range that is between 1.3 to 2.67, you might consider other assessments such as elastography-based assessment. In those that have an elastography reading somewhere between 7.9 and 9.6, you might consider doing a liver biopsy assessment because it's possible that this patient may have any of the stages of fibrosis from stage 0, 1, 2, 3, or 4. However, greater features of metabolic syndrome would be helpful in assessing those with a higher stage of fibrosis, even among those individuals. We currently do not have an accurate biomarker for diagnosis of steatohepatitis and differentiating steatohepatitis from NAFL. Various new tests have been proposed. They're predominantly lipidomic-based modalities where you might find a higher likelihood of detecting NASH, but those require to be validated in larger cohorts currently. Based upon the AASLD practice guidance, we still use clinical factors such as presence of NAFLD on imaging or abnormal liver-related enzymes such as ALT or AST elevations in individuals with features of metabolic syndrome, and then consider doing a liver biopsy assessment for diagnosis of steatohepatitis or fibrotic steatohepatitis. Presence of metabolic syndrome, high FIB4, or high liver stiffness measured on VCT or MRE may be used for identifying patients who are at risk for progressive steatohepatitis. Liver biopsy is also helpful in excluding other causes for elevations in ALT and AST because it's possible that the patient may have other reasons for abnormal liver tests and that a liver biopsy assessment may be required to rule out autoimmune liver disease, drug-induced liver injury, as well as alpha-1 antitrypsin-related disease. Now we will focus on novel treatment options in patients with non-alcoholic steatohepatitis. Based upon the AASLD practice guidance statements, we typically recommend that patients who have biopsy-proven evidence of non-alcoholic steatohepatitis are generally considered for treatment of steatohepatitis. However, I personally feel that all patients with NAFLD should be offered lifestyle interventions because lifestyle interventions may not only improve liver disease-related outcomes and liver histopathology, but also reduce cardiovascular risk among these patients. Typically, what I recommend to my patients who are overweight and obese, a hypocaloric diet, typically a low carbohydrate diet that is deficient in about 500 to 1,000 calories from their usual intake, and increase their physical activity by including moderate intensity exercise for 30 to 45 minutes, 3 to 5 times a week. With these lifestyle interventions, if patients can achieve about 5% of body weight, they can start seeing improvements in their liver enzymes, improvement in their steatosis, and also other features related to liver histology. We need greater amount of weight loss if we want to see a complete resolution of NASH and also improvement in fibrosis. A 10% weight loss is estimated to lead to improvement in fibrosis, and about 7 to 10% weight loss may be associated with resolution of NASH, from reversal of NASH to NAFL. based upon studies conducted by Dr. Ken Kusi as well as NASH-CRN studies in the PIVENS trial and other investigators, we have found that pioglitazone may also be helpful in improving steatohepatitis. Pioglitazone may be used among patients with insulin resistance or type 2 diabetes who have biopsy-proven evidence of NASH in improving liver histology. However, pioglitazone is associated with weight gain, therefore it is not routinely utilized by hepatologists for routine management of steatohepatitis because we are asking our patients to lose weight and the medication as its side effect induces weight gain. Typical weight gain is about 3.5 kilogram to 4.5 kilogram over 2 years. Based upon the ASLD practice guidance, we also utilize vitamin E treatment among patients with biopsy-proven NASH, typically who are non-cirrhotic and non-diabetic. A typical dose for vitamin E response is considered to be 800 units daily. This is based upon data from PIVENS trial conducted by the NASH-CRN, where we showed that 800 units vitamin E is associated with improvement in NAFLD activity score as well as resolution of NASH when treated over 2 years. Are there any issues related to vitamin E use that is relevant when we discuss with our patient? Yes, there are. With vitamin E at 800 units or higher, there is slight increased propensity for increased risk of bleeding. Meta-analyses have shown that vitamin E may be associated with high risk for cardiovascular disease-related mortality, and that's primarily linked to hemorrhagic stroke. Therefore, those with uncontrolled hypertension, anecdotally, I generally wait for their blood pressure to be controlled and then initiate vitamin E treatment. There's increased risk of prostate cancer that has been associated with vitamin E use as well. Therefore, I typically discuss that as well before starting vitamin E use in my patients. There are certain therapies that are not recommended for treatment of NASH, such as ursodeoxycholic acid, because it has not been shown to be helpful. Omega-3 fatty acids also are not used specifically for treatment of NASH as they have not been shown to improve liver histology, although they do improve hypertriglyceridemia. That is typically a common association in patients with non-alcoholic fatty liver disease. Patients who have NAFLD and have morbid obesity, such as a BMI higher than 40, or multiple metabolic comorbidities such as type 2 diabetes, obesity, and obstructive sleep apnea, even up to a BMI of 35, you may entertain bariatric surgery or various modalities that may induce weight loss. However, this should be done after discussions of risk benefits and alternatives with the patient. So there are multiple mechanisms that may be involved in progression of NAFLD leading to steatohepatitis and progressive liver injury. Because of this multiple treatment modalities working at different angles and different stages of this pathogenetic mechanism have been proposed. We have used therapies that are insulin sensitizers, such as PPAR gamma ligands, PPAR alpha and delta ligands have also been assessed, and we will discuss them in a little bit more detail. A group of drugs that are known as FXR agonists, which is farnesylate X receptor that is present in the liver as well as in intestine, may also help improve steatohepatitis-related injury by shutting down bile acid synthesis and improving liver homeostasis and liver-related injury due to lipotoxicity and other mechanisms, including bile acid toxicity, causing fibrosis progression. Obeticholic acid is one of those medications. It is a modified bile acid and an FXR agonist. Based upon preclinical studies, obeticholic acid has been shown to reduce inflammation and also shown to reduce fibrosis in preclinical models. It is also known to shut down bile acid synthesis by inhibiting CYP7A1, the rate-limiting enzyme for bile acid synthesis. It decreases bile acid uptake, increases bile acid secretion, and decreases bile acid absorption. The first data that was available for obeticholic acid in patients with NASH came from Flint trial conducted by the NASH-CRN. In that trial, we included patients with biopsy-proven NASH who had to have a NAFLD activity score of 4 or higher with or without type 2 diabetes, but those who were non-cirrhotic. In this trial, 25 mg obeticholic acid was shown to be better than placebo over 72 weeks in improving NASH-related histologic features. Primary outcome was 2-point improvement in NAFLD activity score without worsening of fibrosis. We also noticed that obeticholic acid led to improvement in one stage of fibrosis relative to placebo in that trial. This led to a phase 3 trial called the Regenerate trial. Regenerate trial is a large trial among patients with non-alcoholic steatohepatitis with stage 2 fibrosis or stage 3 fibrosis. It also included a subset of patients who were thought to have high-risk stage 1 fibrosis as well. The primary endpoint in the intention to treat analysis showed that obeticholic acid at 25 mg orally daily was better than placebo in improving one stage of fibrosis without worsening of NASH. It was 23% improvement in one stage of fibrosis at the 25 mg dose versus 18% with 10 mg dose versus 12% of placebo. In the per protocol population, the improvements were higher with 28% in 25 mg dose, 21% in 10 mg dose, and 13% on placebo. NASH resolution with no worsening of fibrosis was seen in 12% of the 25 mg dose versus 8% in the placebo. Now, looking at these data in Regenerate trial, a little bit more detail is also very helpful. In this particular graph, what I want you to see is we're not only looking at regression of fibrosis, but also number of patients who progressed in these arms. So this gives you a totality of experience as to is the drug is really working or not. So if you look at regression, which is to the right of this, there was significantly higher regression or improvement in fibrosis in those at the 25 mg dose relative to those in the placebo. If you look at the progression, which is to the left side, significantly lower number of individuals had progression of fibrosis in the obeticholic acid 25 mg relative to the placebo group, 13% versus 21%. What happened to the liver enzyme, both to ALT and AST? So you see a significant reduction in the ALT with obeticholic acid at 25 mg relative to placebo, and there's a dose-dependent response both for ALT as well as for AST. Typically, you're seeing that the ALT continues to go down over a period of 18 months, and same thing is happening with AST as well. There's a significant reduction in GGT as well that you achieve the NADR by 6 months. Alkaline phosphatase, there's a slight trend in increase in alkaline phosphatase, although it's remaining within the normal limit, and this is a typical phenomenon we think is related to FXR physiology and FXR activation in the liver. Now moving on to the adverse events seen in the Regenerate trial. Overall, at least one treatment emergent adverse event were not different between the three groups: 83% placebo, 89% on 10 mg, and 25 mg dose group had a 91%. The severity of these adverse events in terms of death or life-threatening events were not different. However, the events leading to treatment discontinuation were higher with the 25 mg dose relative to placebo or the 10 mg dose at 13% versus 6% each for placebo and 10 mg dose. A new drug application has been submitted to FDA for obeticholic acid, and further assessments are being done regarding the approval process for treatment of NASH-related fibrosis with obeticholic acid, and this is under consideration by the FDA currently. As I previously discussed about the Flint trial, we also looked at predictors of histologic response in the trial, and there were 5 notable predictors of response that we found. Of course, obeticholic acid was better than placebo in inducing response. Those patients who had higher disease activity, so higher baseline NAFLD activity score, had a higher likelihood of response. Baseline triglyceride lower than 154 had a higher likelihood of treatment response. A lower INR had a higher likelihood of histologic response. And a baseline AST below 49 was associated with higher histologic response. A key caveat that we noticed that could be used clinically was if a patient started with an ALT of 60 and it went down by 17 points or higher, then that patient had a higher rate of histologic response. And this was at 6-month time point. Now I would like to summarize the Regenerate data that was presented at the liver meeting in 2019. After 18 months of treatment, obeticholic acid was shown to improve liver fibrosis, steatohepatitis, as well as liver biochemistry in patients with stage 1, stage 2, and stage 3 fibrosis, demonstrating consistent efficacy with an overall similar safety profile across the 3 stages of fibrosis among patients with biopsy-proven NASH. There's a separate trial that is being conducted among patients with compensated cirrhosis due to NASH to assess the efficacy of obeticholic acid versus placebo. In that trial, patients are being randomized to obeticholic acid 10 mg orally daily versus obeticholic acid 10 to 25 mg orally daily or placebo. The primary endpoint of that trial is percentage of patients with improvements in fibrosis by at least one stage with no worsening of NASH using the NASH CRN histologic scoring system. Secondary endpoint include percentage of patients with improvement in fibrosis by at least 2 stages using a SHAQ scoring criteria and percentage of patients with NASH resolution using the NASH CRN histologic scoring system. Now we'll discuss some of the other drugs that are also in phase 3 assessment for treatment of NASH-related fibrosis. Elafibranor is a dual PPAR compound. It is a PPAR alpha and a PPAR delta agonist. It is known to increase CPT1 and thereby increase beta oxidation, may decrease gluconeogenesis, and may decrease de novo lipogenesis. Previously conducted Golden 505 trial was the phase 2b trial that provided data as a rationale or justification for conducting a phase 3 trial. In that study, patients who were treated with 120 milligram dose of elafibranor relative to placebo showed a higher rate of resolution of NASH, especially among the subgroup that had a NAFLD activity score of 4 or higher. However, per protocol analysis did not show a significant difference. Elafibranor is hypothesized to lead to resolution of NASH, and thereby that is the primary endpoint for the phase 3 trial with elafibranor. The trial is called Resolve-It trial. It's an international ongoing phase 3 trial in which patients are being randomized to elafibranor 120 milligram orally daily versus placebo. The primary endpoint of that trial is proportion of elafibranor treated patients relative to placebo achieving resolution of NASH without worsening of fibrosis, and composite long-term outcome composed of all-cause mortality, cirrhosis, and liver-related clinical outcomes. Cenicriviroc, or CVC, is an oral dual antagonist of CCR2 and CCR5. In a previous phase 2b trial called the Centaur trial, CVC was assessed relative to placebo. In that trial, we included patients with biopsy-proven NASH with NAFLD activity score of 4 or higher and stage 1 or 2 or 3 fibrosis. We excluded patients with cirrhosis in those trials. The primary endpoint in that study was 2-point improvement in NAFLD activity score with at least 1 point in lobar inflammation or ballooning with no worsening of fibrosis. We also assessed 1-stage improvement in fibrosis as a secondary endpoint. In that study, 289 patients were randomized 2:1:1 into CVC 150 milligram or placebo, or another group getting placebo, and at 1 year, half the placebo patients were re-randomized to CVC 150 milligram dose. Patient underwent liver biopsy at year 1 and again a liver biopsy at year 2. Centaur trial 1-year data showed that there was no significant difference between the treatment arm or the placebo in terms of the primary outcome, that was 2-point improvement in NAFLD activity score. However, patients treated with CVC relative to placebo had higher rate of 1-stage improvement in fibrosis, with 20% on CVC versus 10.4% on placebo at 1 year. The year 2 data showed that there was no significant difference in CVC versus placebo in terms of antifibrotic response. When you looked at patients who had stage 2 or stage 3 who had improvement in fibrosis by 2 or more stages without worsening of NASH, then 11% showed improvement on CVC versus 3% on placebo. There was a numerical difference, although it wasn't statistically significant, that led to the phase 3 continuation and currently the Aurora protocol. Aurora trial is a phase 3 trial of cenicriviroc for assessment of liver fibrosis in patients with NASH. The primary endpoint of the Aurora trial is superiority of CVC compared to placebo on liver histology and month 12 relative to the screening biopsy. Secondary endpoint, superiority of CVC compared to placebo on the composite endpoints of histopathologic progression to cirrhosis, liver-related clinical outcomes, and all-cause mortality. Now we'll move on to Resmetirom, a liver-directed, orally active, selective thyroid hormone beta receptor agonist. This particular drug has been shown to activate beta oxidation in the liver and increase hepatic fat metabolism and reduce lipotoxicity. In a 36-week study, this drug has been shown to be better than placebo in reducing liver fat based upon MRI proton density fat fraction assessment. Looking at the safety data for Resmetirom, no significant difference that were seen in terms of severe adverse events related to Resmetirom. However, they were slightly higher mild treatment emergent adverse event relative to placebo. With the success of the phase 2b program with the thyroid hormone beta receptor agonist Resmetirom, Maestro-NASH trial has been initiated. The primary endpoint is to compare resolution of NASH in non-cirrhotic patients with biopsy-proven NASH with stage 2 or 3 fibrosis relative to placebo, and then also look at composite long-term outcome composed of all-cause mortality, cirrhosis, and liver-related clinical outcomes. Another drug that is also in phase 3 program currently is aramcol. Aramcol is a synthetic bile acid and a fatty acid derivative. In a previous study among patients with biopsy-proven NASH, aramcol at 600 milligram daily was thought to be better than placebo in improving NAFLD activity score, as well as features associated with NASH resolution and trend towards improvement in fibrosis. Aramcol also showed improvements in liver fat based upon MR spectroscopy-based assessment. Therefore, now aramcol is being tested in a phase 3 program for assessment of resolution of NASH as well as improvement in one stage of fibrosis in patients with biopsy-proven NASH in stage 2 or 3 fibrosis. For FDA approval of a particular agent, the population to be treated that has been currently accepted is patients with NASH who have at least stage 2 fibrosis or higher. Typically, we have trials that include patients with NASH in stage 2 or 3 fibrosis as one trial entity, and then trials that are assessing patients with NASH-related cirrhosis in a separate entity. The accepted clinical endpoints for improvement for a drug for NASH-related fibrosis include either improvement in one stage of fibrosis without worsening of NASH or resolution of NASH without worsening of fibrosis. Although non-alcoholic fatty liver disease is very common, the differentiation between NASH and the progressive form of fatty liver disease and need for liver biopsy is a major hurdle in clinical trial recruitment. In conclusion, the progressive form of non-alcoholic fatty liver disease, termed as NASH, is an important cause of cirrhosis and is now the second leading indication for liver transplantation in the United States. There are several newer therapies that are in phase 3 trials for the treatment of NASH-related fibrosis, and the field is optimistic that we will have future therapies become available for our patients who are suffering from NASH-related fibrosis and NASH-related cirrhosis in coming years. Thank you.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.